Good afternoon. I'm Dr. Rumay Alexander, a professor in the School of Nursing at the University of North Carolina at Chapel Hill, and also the American Nurses Association Scholar in Residence addressing racism in nursing. I want to welcome you to this session entitled From the Walls to the Halls, Changing Health Professions Education to Advance Health Equity. We played with several titles before we settled on this one. And we could have said, this is how we do it. Or we could have said, we're going to talk about the way we do the things we do, to quote the Temptations. But we chose the walls to the halls because what we're pretty sure of, even if you didn't understand the genre of music that was being described, that on your walls, in your perspective, schools and organizations and websites, are words like integrity, valuing diversity, excellence in care, rooted in service, and of course, equity. Yes, words matter, so keep them visible, for they communicate who you claim to be as an organization and what you're about. And they serve as a constant reminder to all of your colleagues and those within the walls of your institutions that come and go, that you daily are committed to this work. But because words do matter, they need the assistance of each and every one of us to take them from the walls to the halls, to make them live and active. And so this cadre of esteemed panelists is going to carry you through what you might think about as we talk about curricula issues. If you think about it, this is where it all starts. It starts with the curricula. It's where the seeds are planted, and it is where we continue to water and feed all those within our voice and within our building who are in the educational space about how to care for and be with all. So what you're going to hear is that individuals will be sharing their lived experiences, both pre-licensure as well as post-licensure. We will be talking about what we think you might consider in terms of what to keep in your curricula, what to stop in your curricula, and what to start. And so to kick us off, I now put you in the hands and voice of Dr. Peggy Chinn.
Thank you so much. I appreciate and so honored to be here and to be talking about this project that we have initiated in nursing called Overdue Reckoning on Racism in Nursing. And there will be a link in the chat that everybody can access what we are doing on the website. But we started this project because we were convinced that it is long overdue for nursing to come to terms with the racism that is embedded in everything that we do, and especially in our educational programs. I'm engaged in co-coordinating this project with Christina Nerity from Heritage University in Washington State, which is located on the Yakima Indian Reservation. Lucinda Canty, who is a graduate of the University of Connecticut doctoral program and whose research focuses on the health of African-American women in terms of maternal morbidity and mortality, and Valerie Taylor, who is a nurse leader in a major healthcare system in the Seattle, Oregon area. We started this with an awareness that we desperately need to center the voices of women of color, of nurses of color in our nursing programs and education. And until we take care of the racism that exists in nursing itself, among nurses, among nursing faculty, in nursing research, in the policies that govern what we do in nursing, we will never be able to really address the racism that is a constant black cloud over the care that we provide to patients. And so we called together this a group of people. We didn't do any particular advertising. We just put the word out on email lists and through all of the communication methods that we have. And we started this in the fall of 2019, 2020. I'm sorry, I got my years mixed up. And scheduled a series of 5 sessions on 5 Saturdays in September and October. And we had over 100 nurses joining each session, with at least 30 to 40% of the participants being nurses of color. For nurses, this is a very unusual experience because we live and work in a discipline that is predominantly white, and where the white voice, the white perspective, white values, white culture dominates everything. And so we were mainly focused on making sure that we center the voices of nurses of color. And we asked white nurses to listen and participate in the chat, but not to speak during the Zoom sessions. The principles that guided our actions were the most important part of what we do. We read this at the beginning of every session. And these are principles of solidarity, or principles of reckoning, that we believe can guide other initiatives, actually even what we do in our classrooms and in our clinical areas, to really bring forward our constant awareness of the fact that we will never have equity, we will never have inclusion, we will really truly never have diversity until we deal with racism and establish a very firm anti-racism practice in our own dealings with one another. And so I want to just read through briefly the principles of reckoning and comment briefly on each of them, because I think these are really important principles that can guide all that we do in our educational systems and in our practices. First of all, we claim the courage to join together through the experience of building our anti-racist capacity in nursing. We cherish the contributions and honor the voices of Black, Indigenous, Latinx, and other nurses of color, and yield the floor to those voices throughout our time together. We recognize that we cannot move forward without a deep understanding of Black, Indigenous, Latinx, and other nurses of color experiences with racism. The insights and recommendations of Black, Indigenous, Latinx, and other nurses of color are vital to ground our thinking and to guide our actions. We pledge to listen deeply and with respect to any and all expressions of anger, rage, despair, and grief arising from racism. We commit to healing those harmed by racism. We commit to challenging, resisting, and ending the voices and actions that sustain white privilege. We seek to nurture authentic anti-racist awareness. And I would just comment that while we wrote these together so that the voice who is expressing these principles can be the voice of any nurse, regardless of how she or he is situated in terms of race, culture, and ethnicity, because the threads of racism run so deep that we are all affected by it in terms of our own practices and our own assumptions. And until we begin to truly listen to all of the voices that are in our midst, that are coming from those that we are seeking to serve in a more equitable and just way. We must begin to learn how to do that in our own practices and take it to heart in what we are doing. So I'm going to pass to Dr. Garg, and we'll welcome any questions or discussion you have about this project or the principles on which it is based. Dr. Garg.
Thank you, Dr. Chinn, for sharing your principles with us. I'd like to start by thanking the Hastings Center for hosting the conference, Drs. Alexander and Fair, and it's a pleasure to present with the other panelists today. My name is Priya Garg. I'm the Associate Dean of Medical Education at Boston University School of Medicine and a pediatrician at Boston Medical Center. Over the next several minutes, I'm going to share with you my personal journey and approach to thinking about steps towards advancing health equity by deconstructing racism in medical education as a health professions educator and medical education leader. My hope for today is that we can make structural changes in education, which will lead to the advancement of health for all people. Some of you may wonder why I began with racism to advance health equity at our medical school, and that really begins as a personal story that I will share with you. A group of second-year medical students, now fourth years, came to my office in October 2019 and said that our curriculum was perpetuating racial biases and misconceptions about race. They began to share with me the incorrect associations faculty were making between race and genetics, images that only reflected white skin, research studies being shown that showed higher rates of disease in Black and Latinx patients without a deeper understanding and explanation of the why. That was hard to hear. I pride myself in being evidence-based, both in education and as a pediatric provider. How did I not recognize this was happening? And the first question I posed to myself and I posed to all of you as educators and health professional leaders is to think about what you've done to begin to educate yourself. I encourage you to start your anti-racist work with critical self-reflection at the personal level. What do you know about racism in your community and in your profession? I began educating myself about the history of racism in Boston, which has been longstanding in medicine, the impact racism has had on children. I had a knowledge gap and I'm continuing to learn. There are many different resources and wonderful books we've heard about over the conference. Many I keep trying to read, sites across the country and collections on racism and health that didn't exist before. One note to be conscious of as you improve your education is not to burden the students and faculty of color. Given the fact that all of you are here listening, I assume your educational process has already begun. But to deconstruct racism as a teacher, we have to examine our own knowledge, name racism, and understand that it surrounds us in medical education today. As we heard from Dr. Williams, racism is present in who we admit to medical school, who teaches in our schools, who would advance to leadership in the words we say in the classroom. Whether it's implicit or explicit, it exists. And for all of the educational leaders listening, we have to examine our own beliefs. We've taken a moment, we need to take a moment now and think about our own power and privilege we have. And for many of us, we've had it our whole lives, how that impacts the way we interact with students, the education we design, the lens in which we see the world manifests in the curriculum we design, in the teaching and our leadership. The next point about self-reflection I want to make is it's essential to do at the institutional level. Bring your senior leaders together to assess your institution in the current state in addressing racism, and think about your readiness to make change. I've worked with a group of senior medical education deans and leaders through the AAMC to lead a task force trying to advance our efforts in addressing racism in medical education. We created a roadmap for institutions to help guide this process of institutional self-reflection and have disseminated it for institutions to use. I recommend that all institutions use a formal tool that allows senior leaders at their institution to come together and assess what is happening at every level across the continuum of medical education, and then assess their readiness to make change. The readiness is readiness to change policy, readiness to change processes, to acknowledge that our students of color are disproportionately impacted throughout our education. The second piece of institutional assessment that our school has spent a significant amount of time on is reviewing our curriculum at a really granular level. My next recommendation is that health professional schools conduct a curriculum analysis, systematically reviewing slides, cases, exam questions, looking for the language used, images shared, and whether there are ways to deconstruct racism. Our school's work in this area was published in Academic Medicine in November of 2021, which will be placed in the chat. It includes the process, a tool, resources to analyze your curriculum, and we hope others will use it. There are several themes that we found in our own curriculum, which we believe are practical steps for all health professional schools to start their work. And I'm going to share those over the next few minutes. The first is establish that race is a social construct and do so in the first year of education, whether it's in medical school or any other health professional school. You have to explicitly define for students what's race, what's racism, biology, genetics, and do so throughout the four-year curriculum. When race is identified as a risk factor for disease, it mistakenly implies that race is genetic or biologic and that there's some inherent feature of race that can lead to a particular pathology. This will stay with students as they care for patients and will lead to inequities that we see today. You have to embed structural practices in the health professions education to dismantle racism in medicine. Structural practices to address racism should be added to our instructional design and assessment processes that already exist in our school. Critically examine the use of race in clinical vignettes and exam questions. Do not risk reinforcing race-based pattern recognition of disease, which leads to bias in clinical reasoning and delivery of care. Many of you I know work with national organizations on assessment and may already have best practices, but you have to reinforce this with our ground level faculty. Why are they using race in the case? Develop teams and have experts review cases and questions and think about that question. The next thing students have pointed out across publications in the country is that we need to diversify our clip art and medical images. Much has been written about this, and it's essential to prepare students for practice to have diverse images across everywhere we teach. If we don't provide those images, then we're saying it's too difficult to find dark skin images and perpetuate the idea that being of color is problematic. There are resources that exist now, such as visual diagnosis and others that can be used to find diverse images. Critique the strength of evidence in race-based medical practices. Faculty have to continue to assess what they're teaching and why as it relates to clinical tools, algorithms, guidelines, and be prepared to answer questions. I encourage your faculty to challenge the assumptions and race corrections that exist, and I encourage you to look at articles like Vyas et al. In New England Journal, where they share where these vulnerabilities may exist. Include principal historical cases. Educate our students about the history of racism in medicine as we teach science. They have to understand the history of mistreatment and experimentation. Tuskegee is important, but we have to move beyond Tuskegee with examples in every discipline. And we have to be able to show our students why our patients may have fear and hesitation based on what's happened in history. Define racially based equity competencies in your curriculum. If we want to see change in practice in the future, we have to be intentional about defining the outcomes for our learners in our educational programs. I encourage your educational leaders now to begin that work to see the change in graduates you hope to see in years to come. And finally, partner with students to advance anti-racist goals, but don't place the burden on the students. As faculty and administration, we have to play a key role and a large role in this process. After our curricular analysis, we were able to implement 80% of our 322 recommendations in 1 year by making it part of our continuous quality improvement process that already exists in the school. We have to have accountability for all. So I would end by saying that critical self-reflection, self-assessment has to be done at every level to deconstruct racism in medicine. And what I pose to all of you is, how ready are you at your institution to make these changes needed to deconstruct racism, and have you spent the time to assess that in a systematic way? It's my pleasure to now pass on the mic to Professor Oermann.
Yes, thank you so much. I'm Marilyn Oermann, professor at Duke in the School of Nursing and editor of Nurse Educator. And I'd like to build on what Dr. Garg said about medical education and graduate to share what programs are currently doing at the undergraduate level. And this will be a springboard, I think, for you thinking about what you can do in your own programs. So first, whatever the school's curriculum framework is, I think there needs to be an explicit concept or objective about health equity or DEI, because without that structure and accountability, it's very difficult for undergraduate faculty, especially in large programs, to integrate content and explicit teaching approaches through the curriculum. One course with one faculty teaching health equity or DEI is not enough. So by integrating this in the curriculum in some structured way, faculty then can have some intentional planning about building this knowledge and this learning among students. I would begin next then with curriculum mapping. What concepts are taught in your program in each course currently? What are instructional strategies being used? This mapping will identify gaps in the curriculum, but it'll also provide data for a more intentional approach to curriculum. Look at your own courses. What biases are built unintentionally in your lectures? I teach online in my online modules, in simulation. What do your images look like and your modules? Do cases build diversity and an understanding of the impact of social determinants of health? I think beginning nursing students and students in other health programs should be given ground rules, and the rules should indicate expectations for students in discussions, in cases where they analyze to have a safe environment for exploring ideas, feelings, and personal values. I like to think about teaching for health equity at 3 levels. At the personal level, teaching strategies should help students identify their own individual beliefs, values, and biases. Strategies such as values clarification, bias awareness activities, role play, short video clips or trigger films, and interactive workshops such as theater of the oppressed performance techniques have been reported in the nursing education literature. And oftentimes these methods will help students at what I've called the personal level, identifying their own biases and having bias awareness. At the next level, students should learn how their values and biases impact others. And then at the broadest level, they can learn about social determinants of health and the impact of biases on patient populations and health systems. Video clips, simulation cases, and more recently, studies of using a diversity panel have been used in undergraduate programs to facilitate this level of learning. Altman et al. Recommended that faculty develop clinical cases where students explicitly analyze the impact of systemic racism and discrimination in nursing care and care by other health providers. There are many, many articles in the nursing education literature about individual strategies for teaching DEI that one faculty member is using in that one course in a nursing program. Evaluations of these teaching strategies consistently are only based on student and faculty perceptions and satisfaction. And therein lies the problem. There's not a planned approach, and we do not have evaluations of the outcomes of different methods. Which teaching strategies and where should they be placed in a nursing or health profession curriculum are most effective, and which will make a difference when students proceed through the program, graduate, and are in practice? And now I'm going to turn this over to Rumay and for a 5-minute Q&A.
Thank you. Please continue to put your questions in the Q&A. But to get us started in thinking about just what you've heard so far, which has been really rich. Here's the question, and any of you can answer this. How do you prepare a generation of faculty who aren't ready to teach health equity if you embed the content throughout?
I can answer that. I think it starts with faculty development. None of this will be done. Nothing will be accomplished without faculty development. And the faculty development cannot be a lecture. It can't be sitting and listening. It has to be interactive strategies that people are doing, some faculty are doing with their own students, but it has to start with the faculty. And I actually think, this interesting article that I read about looking at teaching at different levels, beginning with the personal level, kind of that lower micro level, your own values, would really work well for faculty as in addition. We start a lot in programs with social determinants of health and lectures about it. That is not going to be enough, because students don't see it affecting them and their patients and their interactions and what they hear in a clinical setting.
I would just add one thing to that too. this change really has to happen at the level of hearts and minds. And faculty may or may not be ready. I know that many schools of nursing have, and probably medical schools, they have initiated things like having people come in to talk to them, asking all their faculty to read a particular book, like How to Be Anti-Racist, and then discuss it. But the willingness, even though faculty, I would say close to 100% say that they want to do what needs to be done, and when they realize what really needs to be done in changing hearts and minds, their own hearts and minds, that's another question. And so we have to be patient. We have to be generous of spirit. We have to be persistent in inviting people to come along and understand and see the racism that is embedded in everything that we do ourselves and how we can change that.
Yes, you do have to bring people along because people are in different stages. And so what you've described, which I think was most eloquently talked about earlier today or yesterday around filling the empathy gap, is an important piece in this work. So can anyone provide tangible strategies to assure faculty and other staff do not cause harm? You know, that is the big motto, do no harm. And it happens.
Mm-hmm.
And so are there any strategies you would recommend?
A short one that is common in so many situations: if you see something, say something. We have to learn to be able to speak up and not stand by and to be a bystander who does nothing. And we all see things day in and day out, and actually we need to raise our awareness of what those some things are, what is really happening. And I think we have to listen to our colleagues and students of color and take seriously what they are saying to begin to raise awareness of what's happening.
You just described what I call an upstander. Rather than a bystander, be an upstander.
Mm-hmm.
Are there strategies that organizations are taking at the board and examination level that you are aware of? I do think people are beginning to think about, from accrediting bodies, how they might put this as a measurable. That's how you hold people accountable. And people want that accreditation. So, you know, that's one of those places, if you think about it, it could be a political determinant in its own way, because it puts in front of folks that this is important enough that it matters in terms of your accreditation. Yes, Marilyn.
Well, I was just going to say, it's actually, DEI is actually not health equity is too, but I just remember the DEI is built very explicitly in the new essentials for baccalaureate and higher degree programs. But the issue is, when you would do an evaluation of that, it's more at the knowledge level, the cognitive level. You don't really know what people are doing in their own classes, their own feelings, if they are speaking up. So I've never been convinced that some of the credentialing really gets at some of the issues and what's going on in reality. Yeah. It's a start, but I'm not sure. Yes. I think we need more than that.
Yeah, it's definitely a start. You're exactly right. It's what's the dynamics happening in the classroom, and the ability for people to not fear that if they talk about these things, the class might get out of control. And then what do I do? So preparation for that courageous, bold conversation and dialogue, and connecting it to what's happening in the world that people live in and what they can expect when they go out into practice, when they're no longer under us, is an important piece. Was there someone else wanting to add something? Yes.
Can I just add about the accreditation piece? Because I think from listening over the last day or two, I think what we're hearing is that we do need to move beyond this idea of implicit bias training being the checkbox, or that we're teaching social determinants of health, but really, how are we looking at the bigger picture of health equity? How are we embedding things like political determinants of health and other pieces, and moving to those levels that we've heard about. And so that's what I hope that all of our accrediting bodies move to, is really a
Yes.
larger picture of how to, and framework to think about how to really advance equity.
That's real. Thank you, Priya. That's good. And then the last question before I pass this on to hear from Alec. What about graduate medical education and the use of resident-run clinics to see patients with Medicaid patients and attendings to see patients with private insurance? Are you aware of any hospital setting that's prepared to change this fundamentally inequitable delivery model?
So I can start with that. I used to be a program director in graduate medical education, and I think it's an important question. I think the question that is really coming out is, are we providing a different kind of care to our patients who come from our historically marginalized communities? And are we saying that residents and students are their doctors and attendings are for others? And at the heart and principle, we all disagree with that. I think the question, and I don't have the answer, is whether there is a way to use that model to advance and embed faculty to think about. I think we know that our learners are actually quite advanced in many ways from the faculty in the way that they think about racism and many of the intersections. So how do we take advantage of that? How do we think about using their knowledge and skills and then bringing our faculty into the fold? But I 100% agree that we cannot provide different care to patients that are historically marginalized, and our hospital believes in that, and I think many others do.
Yes, the fact of the matter is patients don't like to be experiments. They don't like to be practiced on, but cared for and being cared with the provider. So these are important elements. So now let's hear from our remainder panelists. Alec, will you get us started?
Thank you so much, Dr. Alexander. Miu yam, the tong Alec Calac ka non ataf palmangai, no Tengalish UC San Diego, and Tengalish Pilachilanga Palachi. Hello, everyone. My name is Alec Calac. I'm a medical student at the University of California, San Diego, where I'm also pursuing a PhD in public health at the, UC San Diego Herbert Wertheim School of Public Health and Human Longevity Science and School of Public Health at San Diego State University. I can certainly say that I've had a very interesting week as a native trainee in academic medicine and public health. Last week, I was on a very small call with the White House. Just yesterday, I was on a national news broadcast, and today I'm here speaking to hundreds of individuals, which perhaps is surprising to many as we talk about what trainees do, especially from the most marginalized backgrounds. And for me, one of the smallest groups in academic medicine. And I don't like to think of myself as an expert, but as a learner. I think I bring a different perspective, much like many Indigenous peoples whose perspectives are unquestionably needed, but have been historically disregarded. And for the Calac family, we have a very long history of being visible, and that I know that I have an ancestor who was traveling to Washington, D.C. in the 1800s to meet with President Ulysses Grant to establish the reservations that we now have in San Diego County. So I know that the community that I come from is strong. And as a member of the Palma Band of Luiseño Indians, one of the 18 tribes in San Diego County, the highest of any county in the country, I know that I come from strong people. And the word Palma translates to the place where there is water. And indeed, many people carry the water in our community in very different ways. For me and my father, that path is medicine. My father grew up on the Palma Indian Reservation, left for college, and on a whim applied to Harvard Medical School and is the first physician from our tribe. Nearly 25 years later, here I am, his small little son, as he was navigating medical school through the prestigious halls of Harvard. Also a medical student, and will be the second physician from our tribe. And I, growing up and, using my lived experience to highlight what it is like for Native trainees There aren't that many of us. The number of American Indians and Alaskan Natives going into medicine is the same, if not lower, than it was in the 1970s, for which we start collecting the data. And if you were alive before the 1970s, you lived through the ending of the Indian termination era, where the federal policy towards Indian country was full assimilation and termination of tribal sovereignty. So for those alive and with us today, you are living through a transformative moment for Indian country, where we are seeing the regrowth and the resilience of communities that have survived and been here since time immemorial, but have faced tremendous challenges in the last 5 centuries. And I think to congressional testimony from the CEO for the Association of American Medical Colleges, Dr. David Skorden, in which he said, the near invisibility of American Indians and Alaskan Natives is not just an issue, it is a crisis. Because at many academic centers, we are no stranger to feeling like the only one or one of the few. So when there's no one else, you are the resource. You become the textbook. You are asked to serve on the committee. And as you go through undergraduate to graduate to continuing medical education and practice, you are unable to commit yourself to your full training because you're being pulled in so many different directions. And that's especially true when you're pursuing 2 doctoral degrees. So when I started medical school in the fall of 2018, just a month into school, also at the university that rejected me for my undergraduate degree, I was told by a professor in health policy that the only thing that I need to know about Native American health as a future physician is that if a Native tribe has a casino, they have great healthcare. That was said to a group of 30 medical students. And I had to spend the better part of a year pushing back on that narrative and challenging and speaking up as to why that is simply not true. So when I think about curricula and how it has this deficit framing for Native communities that is rooted in poverty, addiction, disparity, communities that are dying rather than living, it's hard to unpack that, and it's hard to justify to the administration why that should change, why it should shift. A few months after the casino incident, I'm told that being a Pima Indian or having Pima ancestry is a risk factor for developing a cholesterol gallstone. Just a few days later in that same curricular block, I'm told that being Native American is a risk factor for developing a cholesterol gallstone. I asked the facilitator, well, which is it? Is it Pima ancestry or is it being Native American? Do I have the same risk of developing a gallstone than a Pima Indian in Arizona or Mexico? The facilitator, a young resident, didn't have an answer. They were told, this is what my curricular packet says. This is what the facilitator's guide says. In medical education, we're taught to follow a script. We're taught to not question things or to say why things are presented the way that they are. And in thinking about promoting greater inclusion of Indigenous people in medicine, I have to think about what has to change. And I think the term that best captures this is not cultural humility, competency, proficiency, but really cultural responsiveness. And this term really involves recognizing and incorporating the assets and strengths all students bring into the classroom and ensuring that learning experiences from curriculum, pedagogy, engagement with students in their communities is really relevant to all students and is grounded in evidence-based practice. And if you need the data to implement that, please use my lived experience that I shared with you. Talk to an Indigenous trainee, because there's so much that has to change, but we truly need partnership when we are one of the smallest groups. I look forward to the Q&A and really pushing back on a narrative in medical education that teaches me that I am not, it's not possible for Natives to achieve health equity. And with that, I pass on to Dr. Palermo to continue this conversation.
Thank you so much, Alec, and to my fellow panelists for this important dialogue and conversation we're having. My name is Angel Palermo. I'm the Senior Associate Dean for Diversity, Equity, and Inclusion at the Icahn School of Medicine at Mount Sinai in New York City. We are part of a large academic hospital system, and my role is also with our health system-wide Office for Diversity and Inclusion. And I'm going to take you on a bit of a journey of our process of addressing racism and bias in medical education, and begin with the year 2015, when that was the first time in our institution, we heard the term or learned the term anti-racism. In 2015, our Black and Brown students organized and called a meeting and organized to form the Anti-Racism Coalition in allyship with other students from other backgrounds, and requested a meeting with leadership. And leadership included all the deans of all of the functional areas within the medical school. And they presented data that really called out the ways in which the learning environment was perpetuating and socializing our students into treating and behaving and engaging with patients in racist, biased ways. They had data from surveys that they took among the student bodies. They had images from slide decks. They had content from lectures, and they were able to really present a set of issue areas where they also said, we're interested in a strategy to undo all of this. And so through the Anti-Racism Coalition, and that was a pivotal moment in our institution's history, or in our school's history, because we began to start to see the cumulative effects of inequity in the learning environment. There was lack of diversity, lack of inclusion, and inadequate institutional support for students, particularly students of color, superficial and damaging use of race throughout the curriculum, educators being ill-equipped to teach about race, and quite frankly, a slow response to contemporary issues related to race, racism, and racial disparities. The data also centered on the lived experiences of those that are most marginalized and underrepresented in medicine. So as you can imagine, our initial reaction as a leadership team was defensiveness. And we had to break through that, because we started you could not see what was shown to us. You could not know it at this moment. And so what we embarked upon is what we call the Racism and Bias Initiative, and that link will be put in the chat. And so at that moment, between 2015 and the official launch of the initiative in 2018, we engaged in a series of conversations and dialogue within the leadership team to really tackle and understand our relationships with the concepts of power, privilege, white supremacy, and all the sort of things that were really deeply embedded that no one wanted to talk about and were seen undiscussable. So the Racism and Bias Initiative is grounded in the mission and the vision to become a health system and a health profession school with the most diverse workforce, providing healthcare and education that is free of racism and bias. And so in order to do this, it required a systems change approach, really engage in transformational change. We wanted to step into and create a future state, and spend a lot of time designing what that future state, or dream into the future state, which is to have be radically different from the current state and initially what's unknown to us. We embarked upon a change management strategy, and the change management strategy started in 2018 and is led by Dr. Leona Hess, who I want to give a special shout out to, who's really been our guiding light through this entire process. And so transformational change is really getting underneath, right, unpacking the system and revealing the system onto itself. And that meant our educational environment, our medical education training environment, and it meant addressing, what needed to change, how it's going to change, and who was going to be part of the change. And so we engaged in a multi-phase change management strategy that dealt with the content of change. What is going to change? Our structures, policies, practices, systems, the people in the change, our mindsets, our emotional reactions and behaviors, and the process of change, the way in which we were going to actually carry out the change, and how it's going to unfold. We wrote up in Academic Medicine in 2020 a paper about this process and this journey. And I believe that will be also put in the chat. that triggered two things at our institution. Knowing that we had to focus on systems change work and capacity building, we couldn't just focus on one functional area because that meant the other interconnected parts of the system wouldn't be addressed. So recognizing the system as a whole, we were able to, over time, document our process internally and create a strategy where each functional area is represented in what's called the guiding coalition. That guiding coalition develops change targets. So one of those spheres is what's called the curricular affairs sphere. And each year we develop systems or structural oriented change targets to really, again, get underneath, to change the conditions that are holding, quote unquote, the problem in place, that being systemic racism in the learning environment. So if you have a moment to check out the racism bias link and click under change targets and scroll down, you'll see the change targets under the curricular affairs sphere. One of them was to develop a new medical education program objective, and I'll read that out to you, which is now to demonstrate aptitude, recognition, and informed ability to practice and promote transformative change that eliminates barriers for optimal health and act against and educate on systems that perpetuates health injustice and health inequity. That MIPO was developed over inside of the fact that between 2015 and 2018 and beyond, we have been developing a longitudinal curriculum across all 4 years on addressing racism and bias. And so we were finally able to map all of those activities up into a formal medical education program objective. That then triggered a new discussion around the mission of the medical school and being mission driven. And we released in December of 2021, a new mission of the medical school, which is our mission is to nurture a visionary community of students, staff, faculty, and leaders who are committed to advancing exceptional clinical care and science that is free of racism and oppression in all its forms. And being a mission-driven institution, that means that every area is touched by this focus, not just curricular affairs. We recognize that the whole, that the student experience is in admissions, is in student affairs, curricular affairs, diversity affairs, and so forth. And so this is a strategy to engage in dealing with the water we're all swimming in called the medical education environment. The third capacity building initiative, the second capacity building initiative is that we established the Center for Anti-Racism and Practice for our School of Medicine. We're a freestanding medical school. And so engaging in a variety of different areas, one specifically on teaching and learning design, grounded in anti-racist pedagogy. And I just wanted to address some of the comments and questions that came up before around what are those strategies that you can take on to really redesign medical education curriculum. So we've operationalized this particular area of focus within the Center for Anti-Racism and Practice, specifically teaching and learning design and anti-racist pedagogy by creating what we're called curriculum clinics. We created a 3-part curriculum clinic journey, if you will, that includes an assessment tool that we developed. The first curriculum clinic is on starting where they are at in terms of the faculty. And that means specifically dealing with getting faculty to really reflect on how did they learn to teach and how did they learn to become a course director or a clerkship director. And so we started with first critically examining the water, we're using the metaphors, the water we swim in, or the dominant model of medicine and dominant culture ideology, if you will, in the US. We had them really unpack and describe how the biomedical model and white supremacy culture manifests in course design and teaching practices. And it was a focus on thyself first. So I think Dr. Chinn's point earlier about personal self-reflection, self-interrogation was a key component in engaging in this journey. We then take them on to a second curriculum clinic on focusing on racism in the classroom. And so we actually pull out real examples from their courses. The participants of this curriculum clinic are the course directors, and move them through how their course actually, through content examples, learning strategies are actually perpetuating racism in the learning environment and talking about the impact of that. And so there's an assessment piece that's built in that we've had to sort of create from nothing, if you will, which speaks to the opportunity in medical education to generate innovative tools and resources, but also, lean on the social sciences, if you will, and other disciplines to create those tools for the medical education environment. And just to wrap up, we now have been able to share this sort of approach in engaging and transforming the medical education environment with our medical education community, which is an initiative called Art in Med Ed, Anti-Racism Transformation in Medical Education. And the link is in the chat. We have been funded by the Macy Foundation to build the capacity of 11 medical schools across the country to engage in a change management approach to address racism and bias in their institution. And so curricular affairs is a piece of that. Again, it's a systems change approach. It's about identifying the conditions that hold the problem in place and redesigning, disrupting, dismantling those conditions so that we can center equity in those most marginalized in those education environments. So I'm going to stop there and I'm going to hand it over to Malika, Dr. Malika Sharma.
Thank you so much. My name is Malika Sharma. I'm a physician and the education lead for the Division of Infectious Disease here at St. Michael's Hospital in Toronto, Canada. And I'm the program lead for a program called Building the Foundations of Anti-Oppressive Healthcare through the Center for Faculty Development here at the University of Toronto. It has been so thought-provoking listening to the other panelists, and I really want to apologize. I'm sure some of you can see me on and off the phone. I've just been getting paged a lot, but I really, I've been trying to listen to as much as I can, and I've been learning a lot. I thought as the one going last that I would perhaps revisit the objectives of the panel. So you might recall or have in front of you that one of the goals of this panel was to describe the landscape of interest, enthusiasm, early changes, and challenges in incorporating health equity principles in health professions education. I think the first part of this is what's really important. So interest and enthusiasm to do what? So many institutions put out official statements and they send staff emails that express interest and enthusiasm and often proclaim commitment and solidarity to and with groups that are seeking healthcare equity for their communities. At my own institution and across Canada, many medical institutions have issued statements following the death of George Floyd, in response to widespread protests against anti-Black racism, and in response to the so-called discovery of mass graves for Indigenous children who were essentially stolen from their families in what is essentially state-sanctioned kidnapping to be taken to what was called residential schools. I say so-called because Indigenous communities have known for a long time that these graves existed and have been talking about them. It's just the rest of Canada has not necessarily been listening. When organizations respond in these ways and make these statements, what do they mean? What are the limits of their interest and enthusiasm? And essentially, what form does the commitment and solidarity take? What do they actually plan to do? I was reminded recently of a quote from Black feminist scholar Bell Hooks, who passed away earlier this year and said, "What we do is more important than what we say or what we say we believe." And I think it is fundamental that we start to tease out statements that in fact serve to maintain the status quo from tangible action that transforms it. Within healthcare professions education, or HPE, I'll call it for the rest of the 6 minutes that I probably have left for HPE spaces, traditional responses often tend to include several core elements that include 1, the creation of task forces to investigate the problem, 2, development of roles centered around equity, diversity, and inclusion, or EDI, and 3, the addition of educational modules or workshops around specific equity issues. And this is not to say that any of these things are bad or that they are always problematic. And I think we've heard some really incredible examples of educational offerings and restructurings in this talk. So I really want to make sure that I'm making clear that I'm not saying that these are always bad, but I want to just problematize some of these pieces a little bit. So to start, the question of task forces actually goes back to what I was saying about the discovery of mass graves for children at residential schools. So Indigenous people, and in particular survivors of residential schools, have been saying for decades what went on at these schools. And in fact, the Truth and Reconciliation Commission in Canada asked the federal government of Canada for $1.5 million to find these graves that they knew existed. And that the federal government denied that request in 2009. Right, so this discovery that everyone is upset about, people have known about it and actually asked for support to make that discovery, over a decade ago. The cyclical creation of task forces in HPE spaces to investigate the problem of racism and inequity tells us a few things. It tells us that we need yet more evidence to be believed, more evidence to prove that racism exists. To a racialized person, actually, that feels a little bit like needing to prove that water is wet. And that evidence also has to look a certain way. And it also tells us, particularly those of us that are racialized, that we exist outside HPE spaces. because it feels like if we were fundamentally integrated and a part of them, enough of us would be on the inside that we wouldn't be demanding more evidence. Addressing racism in the HPE space often also involves the creation of EDI, or equity, diversity, and inclusion roles. Scholar Ronaldo Walcott says it beautifully when he notes that diversity rhetorics and its resultant practices are a poor attempt at structural justice and societal transformation. And when EDI roles are created, we really have to ask who benefits? Who gets hired for these roles? How are they trained and supported? How are they funded? How is that funding sustained? What kind of tasks fall to the people in these positions, and how are they supported to actually be successful in the completion of those tasks? What resources are they provided to operationalize their mandates? And what happens if and when they are vocal about institutional failings? Does the organization demonstrate a willingness to change, or does the EDI role itself count as the change being made? And there's often an analogy made around EDI that talks about being at a dance, right? Where diversity is being invited to the party and inclusion is being asked to dance. Anti-racist organizer and consultant Rania Elmagamar in Toronto asks, who's hosting the party? Do I even want to be there? Many of the framings of EDI still make it clear who's on the inside with the power to do the inviting and the dance offering. And they do little to question how those very structures may not be places that are safe, inviting, or even desirable to racialize people. Maybe I don't like the music. Ronaldo Walcott says in his paper, The End of Diversity, that something more radical and sustaining than diversity is now required if whiteness is to be understood as the foundation and barrier that preempts non-white others from the structural arrangements that currently govern human life. And lastly, HPE can sometimes resort to an add a module and stir, an attempt to incorporate equity concerns rather than radically transform institutions and reorient them towards the pursuit of justice. I love teaching and I love being an educator, but we also need to be cognizant of the limitations of what can be achieved through curricular interventions, particularly those that simply allow organizations to check a box and say, all my employees have been trained in anti-oppression, because it just doesn't work like that. This work and this content is thorny and it's difficult and it's dialogic. It requires conversation and safety and discomfort and the time to process and reflect and the ability and time and space to revisit. It's not just about what we teach, but also how we teach it. So fundamentally, addressing health inequities will require a fundamental restructuring of HPE and healthcare institutions, requiring understandings of power and privilege and giving some of that up. We need to draw from anti-racist and intersectional feminist principles to think about how we teach and how these ways in fact perpetuate status quo and deepen inequities. Bell Hooks talks about the classroom as the location of possibility. And she also talks about the difference between education as freedom versus education as obedience to authority. And lastly, connecting the thread from earlier in this conversation around statements and declarations versus action, Bell Hooks also talks about integrity, which she describes as when there is alignment between what we think and what we say and what we do. So my question for you is this: how can healthcare professions, educational institutions act with integrity in ways that change systems of power and move from creating and entrenching inequities to actually addressing them? So thank you so much for your time and for this invitation.
Wonderful, wonderful. So there are so many things roaming through my head listening to you all, and we're almost out of time, and I bet the audience is just bubbling with the same types of questions. I will remind people to put your questions in the Q&A so that we can address them. But I want to, before we get into it, ask quickly of some of you, and it may be that all of you want to have that last minute to say something here. So the question was really around, how do we encourage more BIPOC peoples to encourage healthcare professions? If in their spaces and in their places, it's not the best of place for them, and that they're overcoming or having to deal with challenges and what I call layers of thinking that the dominant groups do not have to spend their energy and attention on. Any thoughts from any of you?
Be happy to go first in answering
Sure.
this. I think, outreach has to be early and often. A mentor of mine, Dr. Mary Owen, president of the Association of American Indian Physicians, says that she would start in preschool if she could, because, if you can't see it, it makes it so much harder to envision yourself along this career path. And I'd also throw a word of caution to the use of BIPOC, in that when we talk about BIPOC, we typically aren't inclusive of Indigenous peoples. The I is often lowercase, or it's an asterisk. It's thrown away into other. And it's really a disservice to communities where if you are referencing BIPOC as a whole, but there are no Indigenous people a part of the conversation, you are doing more harm than good than using that term. So I would actually say, if we want to encourage more Black, Indigenous, people of color to go into the health professions, we need to focus on Black students. We need to focus on Indigenous students, students of color individually, and we need to give careful attention to the unique kind of ethical, legal, social considerations when engaging with those communities, but also acknowledging that for Indigenous people, you aren't working with communities, you are working with tribal governments. So, and that distinction is often lost on many. So just a quick 2 cents on that.
Well, I'm glad you brought that up, because when the question is posed, in this case, all those letters were in caps. So I think maybe the source of this question was thinking about some of the things that you also mentioned. But that also reminds me of how much we need to pay attention to labels. And we need to be careful about how we label individuals and we label situations, because labels put people on a path, and that path can be good or bad. In summary, then, what I'll say is that what I think you've heard is that you need a plan, that storytelling is important, that data collection is necessary, that a change management strategy and a theoretical basis is so very, very essential, that you must unpack the systemic issues within your own organizations and then find the courage and the boldness to call it out wherever it is, and not punish those who call it out or diminish those who make known that what may have appeared to be a microaggression to you is a macroaggression to the person who was the object or the target or the recipient. And that you've heard some interesting ideas and ways of being to get at the heart of this. But what I think you heard is that the future is about relationships, and you've got to develop those relationships and that trust in the classroom. And since the future is where we're going to all be spending the rest of our time, we really need to be giving attention to the future. So I will end with this. My mother has a quote, or had a quote, that works in every situation. And I offer it to you because I think it kind of sums us up and brings us to this point. She would often tell me and my 2 sisters, you can't talk your way out of what you behaved your way into. You can't talk your way out of what you behaved your way into. That's what we're talking about here. That message on the walls needs to come off the walls and into the halls in action and thought and being and in presence. Thank you, panel, for this wonderful time and your sharing of your lived experiences and your suggestions about how we can move this needle forward on the health professions education piece. As a reminder, this is another session where you need to close out and then come back in for the closing remarks. It's been our pleasure to be with you today, and we hope that in the days to come, you got your sleeves rolled up, you're ready to make change, and you're ready to ask those bold questions.